Welcome to the next module on the respiratory system. So in this module, we're going to discuss respiratory anatomy, the respiratory system mechanics, all about diffusion of gases across the lung into the bloodstream. Then we'll go on and talk about some tests that we use for the respiratory system, followed by some respiratory diseases. Okay, so I think it's an interesting module. And again, remember, if you have questions, ask your instructor or ask at the tutorials. Okay, so that everything makes sense and starts to fit together. Okay, so let's just start off with the structures of the respiratory system. And the respiratory system is divided into the upper respiratory tract and the lower respiratory tract. The upper respiratory tract includes your nasal cavity, your pharynx, which is the back of your nose and the back of your throat. So we would call it the nasopharynx and the oropharynx, right? So it's that wall at the back of your nose and throat. And finally, the upper respiratory tract is going to include the larynx, right? Which is your vocal cords, that's where your epiglottis is, and that's where your vocal cords are to create speech. Okay. Now, the division of the upper and respiratory tract is typically at the larynx. So below the larynx is considered the lower respiratory tract. And it's considered that way because mainly all of these structures are within the chest. Okay, so the trachea is mainly in the chest. There's a bit of it in your anterior neck, but most of it goes into the chest. And then the trachea breaks into a left and right main stem bronchus, which goes to the left lung and the right lung. And then the bronchial tubes just gradually divide into smaller and smaller bronchioles until they reach a very, very tiny size and they get to the alveoli. Okay, and you have hundreds of millions of alveoli, and that is where gas exchange will take place. Okay, so there's no gas exchange at all in the bronchial tubes, the trachea. The gas exchange takes place in the alveoli. Okay, so let's look at the image here and see if there's anything else to talk about. When we're talking about the thorax or the thoracic cavity, we're really talking, in terms of the respiratory system anyways, we're really talking about everything that's within the chest wall itself. So the trachea, the bronchial tubes, the lungs, and what are at the bottom of the lungs? Well, the diaphragm. Okay, so the lungs are surrounded by the chest wall, which are ribs. Anteriorly, you have the sternum. Inferiorly, you have the diaphragm. Okay. Okay, so let's go over the respiratory system components. And the first part will be the airways. And it'll start with the trachea, which is right below the larynx, right? So below the vocal cords is where the trachea begins. And the trachea will travel downwards into the thoracic cavity and split into the left and right mainstem bronchi. Okay, and the left and right mainstem bronchi will go to the left and right lung, but they're going to branch off significantly. So the left or mainstem bronchi will continue to branch off and make smaller and smaller bronchial tubes until finally they reach the alveoli. Okay, So it's really like the branching of a tree. The branches will get smaller and smaller, just like the bronchial tubes, until they've reached the alveolar sacs. And there's millions of alveolar sacs for gas exchange. So really the whole idea of the airway system is to allow oxygen to be inhaled and get to the alveoli, to then diffuse across the alveoli and get into the bloodstream, and as well during exhalation to allow CO2 to leave the bloodstream, get into the alveoli, and be exhaled back into the environment. Okay, so when we talk about upper and lower airways, the upper airways are typically the larger airways, the trachea and the main bronchi. The lower airways are typically the smaller bronchial tubes. And that'll become important when we're discussing something like asthma, which is typically a lower airway problem. It's bronchoconstriction, so narrowing of the smaller bronchial tubes, and mucus production in the lower bronchial tubes. Okay. And when we're talking about the trachea or the larger bronchi, if we're talking about obstruction there, it's usually from, say, a lung cancer, or from someone who's inhaled a foreign object and it's lodged in their trachea. And of course it needs to be removed, right? So, for example, someone who inhales a peanut and it gets lodged in one of their upper airways, such as the trachea or a mainstem bronchus. Okay, so think of the lower airways as really the smaller bronchioles. Okay, and then the lungs. So the lungs is really where the alveolar sacs are. Millions of them. And that is the only place where gas exchange takes place, in the alveolar sacs, never in the airways at all. And you have two lungs, right? You have a left and a right lung. The left lung has 2 lobes to it. The right lung has 3 lobes to it. What about the breathing mechanism as part of the anatomy? So around the entire lungs, they're surrounded by the rib cage, right? So you have 12 ribs on each side, and anteriorly, most of the ribs come and attach to the sternum in front, right? Your breastbone. Between the ribs are intercostal muscles, and they're going to be important for expansion of the chest wall. Below the lungs are the diaphragm, right? Those are large domes below each lung, and when they contract, they're going to also be involved in chest expansion. Okay? And the lungs themselves are very compliant, meaning they can expand when the chest wall expands, and they can recoil when the chest wall relaxes. And that's how breathing in works, right? The chest wall starts to expand by muscle contractions of the diaphragm and the intercostal muscles, which then expands the lung with the rib cage and the diaphragm, because the lung is attached to the inner rib cage and to the diaphragms. Okay, so it's important to understand that concept, that taking a breath in is an active process. Your intercostal muscles are expanding the chest wall. The diaphragms are going down, and by doing that, the lung, both those processes take energy, by the way, ATP. And by doing that, because the lung is attached to the inside of the thoracic cavity and to the diaphragms, during the expansion of the chest and the diaphragm, the lungs get pulled with it and they expand and air goes inwards. Okay? And that's called lung compliance. And lung recoil is once you're fully inhaled and the intercostal muscles and the diaphragm relax, then the lung wants to recoil to a smaller size. Okay, we'll go into that a bit more on another slide. And then there's the respiratory control in terms of the respiratory rate and the depth of respiration, right? And that's controlled by chemoreceptors in the brain that are constantly monitoring blood gases and pH in the bloodstream. And by assessing the blood gases such as O2 and CO2 and as well the pH, they send signals to the lung to either take faster breaths or deeper breaths or slower breaths, whatever is required to maintain homeostasis. Okay? Remember, everything is about maintaining homeostasis. Okay, let's talk a bit about respiratory infections. So when we have an upper respiratory tract infection, that might be a pharyngitis, which is the medical term for sore throat, right? So the back of your throat is your pharynx. So a pharyngitis is inflammation of the back of your throat, typically from an infection. Sinusitis, well, you have sinuses, which are empty cavities in your face. So you have a frontal sinus above your eyebrow. You have maxillary sinuses in your cheeks. And the purpose of having sinuses is that the bones are much lighter because the sinuses are empty, right? So we don't have solid bones in our face. We have sinuses that make the facial bones much lighter. But sometimes they can become infected, okay? Often with nasal congestion or just a typical upper respiratory tract infection, you can also develop a sinusitis, which is pain and pressure and infection coming from one of the sinuses. Rhinitis is just the term for inflammation of the nose. And that can be a runny nose, that can be a stuffy nose. You can have a rhinitis from a virus, or you could have allergic rhinitis. Okay, so it just depends on what's causing the rhinitis. You can actually have allergic sinusitis or an infectious sinusitis. Laryngitis is inflammation, typically from a virus, of your larynx. So you lose your voice, right? You can have a sore throat for it, but it's usually some degree of loss of voice that tells us that somebody has laryngitis. What's a laryngectomy? Well, that's actually removal of your larynx, or a portion of it. And by far the most common reason for having a laryngectomy is laryngeal cancer. And how do you get laryngeal cancer? Cigarette smoking is by far the most common cause. What about oral thrush? What's that? Well, that's candidiasis in your oral pharynx, right? So at the back of your throat. And that's a common condition in children, not so common in adults unless they have an immunosuppressed condition or they've been taking a steroid inhaler. Okay, those are the most common causes of thrush in an adult. Use of a steroid inhaler for COPD or asthma, or some kind of immunosuppression, or the use of an antibiotic has resulted in oral thrush. What's epistaxis? A nosebleed, right? So we won't spend too much time talking about nosebleeds right now. So most of the infections of the upper respiratory tract, whether it's pharyngitis, sinusitis, rhinitis, laryngitis, they're usually all viral infections. The vast majority of them, over 90%, are viral infections. Now, can you get a bacterial sinusitis? Sure you can. Can you get a strep throat? That's a strep pharyngitis. Absolutely. But the vast majority are viral. Okay? What about lower respiratory tract infections? So a lower respiratory tract infection, we're typically talking about a pneumonia. Okay? And pneumonias are an infection of the lung itself, right? So it involves the smaller bronchioles and also the alveolar sacs. And pneumonias can be viral or bacterial. And you can imagine, since they're involving the alveoli, they're going to impair gas exchange because some of the alveoli are going to be filled with fluid and infection from either a virus or a bacteria. So we'll talk more about pneumonias on another slide. Can you have a lower respiratory tract infection of your bronchial tubes, such as a bronchitis? Sure you can. We call it bronchitis. Most of those are viral. Okay, so we really try hard not to use antibiotics in a typical patient that's coughing, doesn't have a pneumonia, and just has a viral bronchitis. In terms of treatments for pneumonia, we do use antibiotics, even though some of them are viral, but we can't distinguish on examination or on chest x-ray which ones are viral and which ones are bacterial. So we treat all pneumonias with antibiotics. Okay, so on to the last topic there, aspiration. So let's just say we're sitting down and we're excited to watch, say, a football game, an NFL football game. And it's the beginning of the game, and we're popping peanuts into our mouth. And we're laughing at the same time, and suddenly a peanut goes into your trachea. It's much more likely to go down the right mainstem bronchus than the left mainstem bronchus. Why is that? Because the right mainstem bronchus is really quite vertical, and it's at a similar angle to the trachea. Whereas the left mainstem bronchus, you really have to turn a corner from the trachea to then get to the left mainstem bronchus. The angle is very different. So most aspirations will go into the right lung. So if we have a patient who's semi-comatose and they vomit, most of the vomit when they aspirate into their lung is going to go into their right mainstem bronchus, or any foreign body such as a peanut. Okay, typically the right lung is going to get the foreign body. Okay, so what are some defense mechanisms of the respiratory system? And we can start with large particles that end up in the nose. So your nose has hairs that can trap those larger particles, and the nose also gives off humidified air, right? So we all know that when we go into cold air and we inhale deeply, we start to cough. And that's because the trachea and the bronchial tubes, they want humidified warm air. They don't want cold, dry air, okay? So breathing through your nose not only traps large particles, but it warms and humidifies the air. You have this clearance system called the mucociliary clearance. And these are tiny little hair projections called cilia that are in your trachea and in your bronchial tubes, and they produce mucus. And what does the mucus do? It traps the smaller molecules and debris that have made it in to the lower respiratory tract. And as the debris sticks to the mucus, the cilia can gradually move the mucus up the trachea for it to be coughed out. So this is a fantastic system. It reduces the chance of developing a potential pneumonia because the mucociliary clearance is constantly working. And what stops the mucociliary clearance from working? What stops all those millions of hair cells from clearing out the smaller debris? Pollution and cigarette smoking, right? It harms the cells and stops the cilia from working. The next one is reflex bronchoconstriction. So I kind of mentioned this already. If you inhale something that's highly irritating, such as cold air, or very noxious fumes in the air, or some kind of chemical that's incredibly irritating to the lungs, your lungs will immediately bronchoconstrict. So in the bronchial tubes, they will bronchoconstrict and clamp down and become much smaller to stop any more of the toxic air from getting further in to the lungs. So that's a pretty amazing reflex as well. Coughing, very useful reflex, right? That allows you to clear the particles in the phlegm or the sputum out of your lungs. And one of the issues with older patients when they get a chest infection such as a bronchitis or a pneumonia is that their cough reflex is very weak, right? Their intercostal muscles are weak. Their diaphragm is weak. They can't take a good cough. So the particles in the phlegm just constantly sit in their lower respiratory tract. And finally, there's alveolar macrophages. So if you remember from immunology or from pathophysiology last semester, you have macrophages all over your body, in your skin, in your liver, in your spleen, in your lungs. And what do? They just hang around these particular organs, waiting for potential infection to come their way so that they can cause inflammation and phagocytose the cells. Okay, phagocytose the infection, such as the bacteria or the virus. Okay, so alveolar macrophages are really throughout the whole lung as part of the immune system. Okay, so the respiratory center is in the brainstem. Like a lot of automated systems that are in the body that don't require our input, they are often in the brainstem. Okay, so for example, the vomit center, the respiratory center is just another example. We have central chemoreceptors that can detect and monitor the pH, the PaCO2 and the PaO2 in the brainstem. Okay, so PaCO2 is the partial pressure of CO2 in the bloodstream. PaO2, partial pressure of oxygen in the bloodstream. So for example, if the chemoreceptors detect that there's an increasing CO2 level in the bloodstream, they can send a nerve signal to the lungs to breathe faster. And by breathing faster at a higher respiratory rate, you blow off CO2, okay? And that lowers the CO2 level in the bloodstream, and the respiratory rate goes back to normal. Okay, and that's exactly what we do with a ventilator. If someone's on a ventilator and we notice that their CO2 in their bloodstream is starting to climb, all we need to do is increase the respiratory rate a bit, and they breathe off more CO2. The CO2 goes down in the bloodstream. Okay, so central chemoreceptors. There's also peripheral chemoreceptors that are in the large arteries of the neck, the carotids, and in the aorta. And they can sense oxygen levels, right? So if you have hypoxemia, so low PO2 in the blood, which we call hypoxemia, then that's going to stimulate increased respiratory rate as well. Okay, so there's an autonomic nervous system that innervates the respiratory smooth muscle, which are in the bronchial tubes. Okay, so what can the sympathetic nervous system and the parasympathetic nervous system do? Well, the sympathetic nervous system that innervates all of those bronchial tubes, when they're stimulated with epinephrine or norepinephrine, they lead to smooth muscle relaxation and bronchodilation. Okay, so by stimulating the sympathetic nervous system, you get bronchodilation, which allows more air passage in the bronchial tubes at a faster rate. What about the parasympathetic nervous system? Well, that also innervates the bronchial tubes, and it leads to bronchoconstriction. So the smooth muscle that wraps around the bronchial tubes, the parasympathetic system, using acetylcholine as its neurotransmitter, leads to bronchoconstriction. Okay, so we actually have two ways of making the bronchial tubes wider or larger. We can use beta-2 type drugs, which are going to bronchodilate, or we can use drugs that block the parasympathetic system. So we have inhalers that are beta-2 agonists or muscarinic antagonists, and we'll talk about that. Okay, so we can stimulate the sympathetic system, or we can block the parasympathetic system, and we get bronchodilation by doing both of those things. Okay, so when you think of the respiratory system control, think of the central chemoreceptors, the peripheral chemoreceptors that are going to monitor your CO2, your O2, and your pH. And on top of that, you have an autonomic nervous system that can control the size of the bronchial tubes. Okay.